My name is Dr. Sue Ling Ching. I'm a cardiologist and a cardiac rhythm management specialist. When people find out what you do, what's the most common question you are asked? I'm often asked if I'm a cardiac surgeon. I think there's a difference that the community doesn't necessarily know about a cardiologist, whether we're an interventional cardiologist, proceduralist, or a cardiac rhythm cardiologist like myself. For myself, I think the easiest way to explain it would be dealing with electrical rhythms. I'm much like an electrician. What drew you into cardiac care? I initially decided I wanted to do cardiology when I was fascinated with the 12-lead ECG, and that 12 squiggly lines could tell you so much about the heart. Where a patient was having a heart attack, which blood vessel needed opening, and then very quickly see the results of that vessel opened and a heart attack averted. What is the one thing about your specialty that you think people would be surprised to hear? I think for me, that cardiology is fun, it's enjoyable, it's rewarding, and perhaps not as difficult as some other specialties. People often use the terms heart attack and cardiac arrest. What's the difference? So a heart attack occurs when there's a blocked heart artery and there's not enough blood supply to the heart muscle. Cardiac arrest is different. There is not enough circulation and the heart pump actually stops working, either due to a slow heart rhythm or life-threatening rhythm disturbance. What's the one piece of advice you would give someone who has chest pain? Don't ignore it. Chest pain can be a sign that something significant is going on, and you may not get a second warning. Is there a difference between presentation in men and women when they are having a heart attack? We often say that women present very differently with coronary events and cardiac events or heart attacks. Women can present in very atypical ways. So the standard chest pain, chest pressure, breathlessness may not present, and it could be something such as dizziness or just feeling unwell, nausea, etc. Who is at greatest risk of a cardiac event and why? We are aware that patients who have all the standard risk factors are at very high risk of cardiac events. They include high blood pressure, diabetes, high cholesterol, family history, and smoking. What is the biggest myth about cardiac care? I think the biggest myth about cardiac care is around presentation of heart attacks. Many people think and expect that there should be chest pain, but for some people it's just a chest or an arm discomfort, and sometimes it may present a bit more atypical, such as breathlessness, nausea. When should people having chest pain call 000 for an ambulance? I usually advise my patients if they have had prolonged chest pain, particularly if they've been prescribed medications such as anginine to relieve pain, and that hasn't helped after 1 or 2 tablets or 1 or 2 sprays, that they should call the ambulance. If there's severe or excruciating pain, if the patient has collapsed, or if you're concerned and unsure, those are good reasons to call an ambulance. What are the things that people can avoid to lower their risk? I would suggest that they see their GP regularly and ensure that they've got their risk factors under check so that their blood pressure is at target, their cholesterol profile is at target, they stop smoking, exercise adequately, and they have a good diet. What's changed in treatment and survival rates in the last 20 years? Cardiology is a very lucky field, and there's a lot of advancements in many areas. I think that we're responding to cardiac emergencies a lot better, a lot more promptly, and that ends up in heart attacks having less consequence on the patient. What has been the most recent advancement in treatment? So we have devices that are able to help the heart to beat more efficiently, and that in turn leads to patients improving from their quality of life. And we've had patients who've been breathless, not being able to leave their house, to then being able to play bowls or go shopping. And that change in quality of life is astounding. Looking at research that's underway, how do you see treatment could change in the future? I would imagine that we would have a whole lot more medications, perhaps medications that are even better targeted to the individual patient. I would also think that with devices, we would have devices and procedures that could fix things in a way that would be a lot less invasive. When people pull a muscle, During exercise, they often get treatment from a physio. How important is cardiac rehabilitation? Patients that do cardiac rehabilitation tell us that they feel better in themselves, they feel more confident about what they can do, and they also understand better what's happened to them and what they can do in the future. What's the most important thing you want anyone watching this to know? I think it's important for our patients to know that after a significant cardiac event, that there is the hope that they can return to a good and normal quality of life.